Good afternoon and welcome to a new episode of Her Voice, the show that's dedicated to the independent modern woman in society. To be diagnosed with breast cancer is devastating. Women report that they fear breast cancer more than heart disease, even though they have a better chance of surviving breast cancer and later dying of stroke or heart failure. Breast cancer has been with us since the early Egyptians, and fear of this disease, as well as the treatments for it, seems to be inherent in women all across the world. In today's show, we will be asking the experts, how is breast cancer clinically detected and treated? What choices do women have if they are diagnosed with the cancer gene? What are the advantages and disadvantages of breast reconstruction? These are some of the questions that we will be asking our experts in today's show. But first, let's watch this report that highlights this global disease.
Breast cancer is the most common cancer affecting women. Globally, about 1.4 million new cases are diagnosed each year. Breast cancer incidence varies considerably throughout the world. According to breast cancer research, there were an estimated 1.4 million cases worldwide in 2008, and there is no part of the world where breast cancer is now a rare form of cancer. In all major regions of the world, breast cancer is the commonest or second commonest cancer in women. Focus on breast cancer up until now has almost entirely been on the situation in high-income, westernized, industrialized countries. However, there is a world out there where cancer is a major and growing problem facing public health. With the growth and aging of the world's population, notable increases in life expectancy in people of lower income levels in many countries, and the increased tendency to adopt a westernized lifestyle, cancer is a rapidly growing global problem and not one that the majority of the world is ready to cope with. Today, there is no population around the world with a truly low risk of breast cancer, and no woman in the world at a truly low risk of developing the disease. The global burden of breast cancer doubled between 1975 and 2000. It seems certain to double again between now and 2030, and the great majority of this burden will fall on low-income and lower middle-income countries, where the resources to deal with the current situation, never mind future increases, are absent to a great degree.
Breast cancer is a major health problem globally. Around 45% of breast cancer cases and 55% of breast cancer deaths occur in low and middle income countries. This is because managing breast cancer in low-income countries poses a different set of challenges, including access to screening stage at presentation, which is the adequacy of management and the availability of therapeutic interventions. To shed more light on this global disease, I have with me in the studios Ms. Caroline Payne, consultant plastic, reconstructive and cosmetic surgeon and head of department and clinical lead at Barb's Health Plastic Surgery Department. And also with me is Dr. Abir Khalifa, who's a pediatrician, but also a BRCA1 carrier and breast cancer sufferer. While we also had with us on the line Mr. Anthony Petterfinkel, consultant journal and breast surgeon. First of all, I'd like to start with asking you, what is breast cancer?
Essentially, in the body, all cells have the ability to divide, and it's a controlled process. So cancer is essentially when that control is actually lost, and there's an irregular, uncontrolled multiplication of cells. And when this occurs in the breast, it is breast cancer, and it can vary from a small area of change to large areas that can be felt.
I see. And how do you actually clinically detect breast cancer?
Breast cancer can present in many ways. One of the most common ways it presents is by a lump. So either the patient notices or the patient goes to a GP for something else, and during examination you may notice a lump. So a lump is one of the commonest things. The other symptoms that patients present often with is nipple discharge. So you can have a fluid coming through the nipple, which is abnormal. Very commonly, bloody discharge can be a sign of breast cancer. There can also be changes in the shape of the breast. Sometimes there can be a puckering or an irregularity on the surface of the breast that can also indicate breast cancer.
I see. And if you actually suspect that a woman has breast cancer, what happens from the point of diagnosis to managing the condition?
Yeah. Well, one of the things that all women should do is obviously go to your doctor if they suspect breast cancer. And nowadays we have a very rapid system of referring to the hospital. Once they go to the hospital, they will be examined by a breast doctor or a surgeon. And have tests such as mammogram and ultrasound scan, etc. And most commonly there will be a little test to take some tissue to diagnose breast cancer. Once cancer is diagnosed, I have to say breast cancer is very well treatable now, and so that's very reassuring, and things have moved on since the last 10-20 years. The first bit of treatment is actually to remove the cancer by means of an operation. This is the first line of modality in most cases. So the cancer is removed by means of, there are two ways of doing it, either by doing a lumpectomy or by removing the breast. In the past, you would have heard all cancers were managed by doing a mastectomy, that means removing the breast. But nowadays, in roughly about 70% of cases, we are able to do what we call as breast conservation. That means we are able to remove the cancer with a little bit of extra tissue around it, what we call as a lumpectomy, and then treat cancer effectively. However, with a lumpectomy, you always have to give radiotherapy to the breast. Radiotherapy is strong X-rays that the breast is subjected to, and it's essentially a method of to prevent future cancers from the breast from happening. There are also two other modalities that are commonly used. One is chemotherapy, which is used for other cancers as well, which essentially are injections, and also hormone therapy, which is a sort of a tablet treatment. They are to combat the estrogens, which have some influence on breast cancer. So they are essentially anti-estrogens that are given in a tablet form. The usual therapy for that is around 5 years. So one tablet a day for 5 years.
I see. And in your opinion, do most breast cancer patients recover from this most common form of cancer?
Oh, absolutely. If you look at the way breast cancers have changed over time, the number of cancers that we diagnosed have significantly increased. And if we're looking back over the last 10-15 years, it has increased from around 30,000 cancers per year in the UK to roughly around 50,000 cancers now. However, the mortality from the cancers have reduced over that period from roughly about 15,000 to 12,000. So cancer survival has significantly improved. The expected survival at 10 years is around 78% now for all stages of cancer, and the 5-year survival is about 85%. For the earlier cancers, we are talking about 95 to 98% survival. So it's extremely good.
That's good to know. That is very good to know. But are they at risk of relapse? And if so, why? And how does that happen?
Yes, there's always. We always say that cancer is, although can be, although the intention of treatment is to cure the cancer, we always have to be vigilant for recurrences, and recurrences can sometimes happen. So most patients have a regime of having mammograms done every year for 5 years. If they're younger patients, they will carry on mammograms up until the age of screening, which is 47 to 50 years, and then go on to 3-yearly screening after that. So cancers can recur. It's not that common. The most common period of recurrence is in the first 5 years, and thereafter it decreases roughly to around 0.5 to 1% per year for the next many years. So it can happen, but even if the cancer recurs, it can still be treated. We can remove areas. We can give second-line medications or chemotherapy and so on.
Okay. Well, thank you ever so much, Mr. Anthony Petithenkel, Consultant General and Breast Surgeon in Essex. Thank you ever so much for joining us today.
That's fine. Thank you.
I just wanted to ask you, Ms. Payne, back in 2013, Angelina Jolie startled the world by announcing that she had both of her breasts removed to prevent cancer, because she had been found to have a specific BRCA1 mutation that results in a high risk of cancer. I'm sorry I have to read this because this is all quite scientific for me. So can you tell us, what is BRCA1 and how is it possible to protect women that are genetically susceptible to breast cancer?
Okay, BRCA1, BRCA, breast cancer. Breast cancer gene 1, there is a breast cancer gene 2 as well. So breast cancer genes it's been a wonderful opening in research to understand that you can be screened for these particular genes. So they do lead a much higher propensity to your general population to getting breast cancer. If you have BRCA2, it also includes ovarian cancer.
Right.
So now we have ladies that have an understanding that previously all they had was an understanding they had a high family history. So in other words, their mother died, sister died, aunts. But now they can be focused in with a genetic test to say they have a high risk because they have this gene. And it's up to them now, really, what they can do to protect themselves. And Angelina Jolie, I think, was very honest and very open, and it has led far more people to come forward to A, get tested, and then to decide how are they going to go and take this forward. Because it, with a BRCA1 gene, gives you about an 80% chance in a lifetime of getting breast cancer.
Right, I see.
So protection, I'm afraid we haven't got a magic, as they call the magic bullets, to try and repair that gene. Maybe that's something futuristic, but really it's down to the fact that, as Angelina Jolie had, she had to have both inside the breast tissue removed, not necessarily the skin, so you can release the skin envelope, but just remove the breasts. And that's where my part comes in anyway, for it's the reconstruction and discussing with these ladies the type of reconstruction.
Well, we are coming to that in a moment. Dr. Abir, I wanted to ask you, you're a BRCA1 carrier, as both your father and mother were cancer sufferers. Could you tell us more about your condition, please?
I inherited the BRCA mutation from my mother. And luckily she actually, she had breast cancer, and luckily she actually had been tested, and we know exactly the mutation, what she had, and that's made it easier for me to go ahead and to look for the exact mutation, because it can be quite difficult in families who have a family history of breast cancer and not knowing exactly what the type of mutation is to detect exactly that what type of mutation that they have.
I see.
So, so yes, I had breast cancer back in 2005, and I had surgery, chemotherapy, radiotherapy. I had also a hysterectomy, which is removal of the ovaries, which will actually reduce the risk of the woman who had by 50% of developing breast cancer. So I thought that was good enough for me to, to have enough treatment. But unfortunately, 7 years later, I had recurrence of my breast cancer, 2 recurrences. But I had more treatment, and I'm currently on some trial medication for, which is working so far.
Fantastic,
Yeah.
fantastic.
Yeah.
I'm glad to hear that. Ms. Payne, can you actually elaborate more about breast reconstruction following surgical removal of the breast cancer?
Yes, I mean, what we try and give is the whole range of reconstruction options. But just to step back slightly is the fact that there are several different groups of patients that I see in the clinic. Those that are going under what we call an immediate mastectomy,
Yes.
so the removal of the breast, and they have to make quite a tough decision
I
about
can imagine.
understanding their disease, but also wanting a reconstruction. So it's a lot to take in. So I have those sort of patients that are sort of feeling, I want to get the cancer out, but I'm now thinking of a reconstruction. And that's sometimes very difficult. And then I have the ladies that have finished their journey. They have had their mastectomy, radiation treatment, been signed off. It can be several years down the line. And then they have this desire to be a bit more womanly, a bit more self-esteem, to have something that they can put clothes on or get changed without feeling uncomfortable. And those are a separate group who are wanting reconstruction. So when I see these ladies, it's basically individual. There is no book that I can say, right, just pick one of these, and that will be what type of reconstruction.
Yes, I
so
can imagine. Yes.
it's honed in to each person. So the reconstructions, when they say there are simple reconstructions, I don't think any surgery is particularly simple, but it is a case of, from a point of view, just having an implant reconstruction to all the way of using their own tissue. So there is something that is a fairly quick operation and gives them a breast at the end, but you have to use a foreign body, which is an implant.
I see. Yeah.
Or you can go to the other end, which is using their own tissue, if they have it available, to then reconstruct their breasts.
Right.
So these are the sort of discussions that we have after you've had the cancer removed, the breast removed, and it all depends whether the skin is removed as well, that we can then start going down this route of discussing all about the reconstruction.
Right, right. What do you think of the process, and what value does it have to breast cancer patients? I mean, do they value it? I mean, in terms of
Immensely.
what you're doing? Yeah.
I find two words there quite difficult, in the sense of I can't process a patient.
Yes.
We're not a production line.
No.
You know, it is a case that I know that there are words that people tend to say, but we're a very strong team that involve the oncoplastics, the oncology, medical genetics, breast care nurses. I'm just part of that team. And what we have is to come to the right conclusion of what is right for these ladies and their goals. So we set out also with I forget to say the clinical psychologist, but she's very important.
Yes, I can imagine.
About
yes.
setting out what it is.
Yeah.
And I was talking to a lady yesterday in my clinic, and I said to her, I'm going to come and discuss. We have patients, people, ladies that have gone through this, and I'm trying to put over their view. And I said to her, what do you value by the fact of having a breast reconstruction? Because she's going to go and have her mastectomy next week. And she said, I want to see that there's something there when I wake up, so that I can feel my self-esteem for my husband as well, and that I can feel that I haven't lost something completely. I mean, you may agree with that. I mean, it's just...
Yeah, exactly.
But it's highly valuable, and it is something you can't put a cost on, unlike we've removed the cancer, we're going to improve your chance of survival. This is totally quality of life.
And how, in your view, Dr. Abid, I mean, how was it for you having to go through the whole process of, doing the breast cancer and the actual process of having breast reconstruction? How did that come?
I actually had lumpectomy, which is just removal of the lump of the mass, and also of the lymph glands which were involved. That's why I ended up having all these sort of like the chemotherapy and all the other treatment. But some women choose to have the actual mastectomy, which in my case, because of the family history, they can go ahead and have removal of both breasts on the same table if they wish to. I was advised at the time that in my case, it's okay, don't have to do it at this stage, and maybe I can do it at a later stage. I still didn't have the courage to to go ahead and do it yet.
Of course.
As you mentioned, every patient is different, and psychologically, and your image, and so I'm still haven't decided. I'm still in the process of like thinking about it. But some women. But I thought I had oophorectomy already, which is removal of the ovaries, which will already reduce my risk by 50%.
Yes.
So at the moment, I haven't decided yet to do that. But I have other family members who choose to do the test, which luckily it was negative.
Very good.
But in case if it was positive, she was going to have her breasts removed and ovaries removed as well. This, I mean, it varies. I've got other family members who are really worried to actually go ahead and do the test, because it's a very, if you have a positive result, then you will live all your life thinking that there's a 65% risk of breast cancer, BRCA1 carriers developing breast cancer by the age of 70, and about 40% of patients with BRCA2 will develop also breast cancer. So, and also ovarian cancer, which is about 40% in BRCA1 patients. So by the age of 70 years. So, in spite of that, unfortunately, I had one family member who had both breast, which she survived breast cancer, but then she developed ovarian cancer later on. So it's a difficult
time,
time when you have to decide what's best for you.
I can imagine.
And there are lots of implications, as we mentioned, psychological implications, insurance, even implications on some patients, you know.
Absolutely.
But
what are the advantages and disadvantages of breast reconstruction, Ms. Payne?
I think, I mean, a great advantage is the fact is we can offer breast reconstruction. It was, if you just go back 50 years,
So
it's a
50
case of...
years. Oh, right.
So,
okay.
well, yes, I suppose, well, the
now.
first
Yes,
breast
yes.
implant was 1960-something, I suppose. So,
Right, okay.
yes, so breast
incredible.
reconstruction, but the development and research into what can be offered. So the advantage is, I think, that there are so many types of reconstruction now that can be offered. And it just has to be totally discussed with the patient, with the lady, of what is suitable for them.
Yes.
I know that some people can't quite or don't want to have a foreign body. And that can be quite strong in people.
Yes, of course.
And then the advantage or disadvantage of having that. But then sometimes the choice is taken out of their hands a bit, because obviously if you have radiation, an implant is not going to cope with being radiated. So we have to look at different reconstructions.
We do want to talk about this in
Oh,
a
right.
minute. Yes, definitely. I mean, you're bringing up some wonderful sort of, ideas and new things that, women should be aware of.
Yes.
But actually, 521,900 is the estimated number of breast cancer deaths in women worldwide in 2012, but mainly in underdeveloped countries, such as parts of the Middle East and Asia. Let's take a closer look at some facts and figures relating to this disease.
The American Cancer Society, in partnership with the International Agency for Research on Cancer, released a new report on the global cancer epidemic, which provides data into cancer incidence and mortality worldwide. 14.1 million is the number of new cancer cases diagnosed in 2012 worldwide. More than half of these, 8 million, occurred in economically developing countries. 8.2 million is the number of cancer deaths in 2012 worldwide. 1,676,600 is the estimated number of new breast cancer cases among women worldwide in 2012. In the Arab world, a scarcity of data is remarkable. Some countries either have a national or regional registry, while others have no data. However, breast cancer is the most common cancer in Arabic women and affects younger women more than their counterparts in industrialized nations. Clinical observation from Arab countries and comparative age standardized rates and age-specific standardized incidences show that breast cancer is seen in younger groups. The median age of breast cancer in Lebanon is 52 years, with 49.1% of cases younger than 50. Compared to 63 years for developed countries such as the US, with 50% of cases over 65 years of age. Mastectomy rates in Arab countries are high, amounting to 79.9% to 82% in Egypt, 65% in Oman, 70% among Palestinians, 88% in Syria, and 82.4% in Tunisia.
Ms. Payne, the reconstruction process, does it affect monitoring breast cancer patients and interfering with radiology?
No. Everything has to be safe. The primary aim of all what we do is to remove the risk of the cancer. So the mastectomy is the primary and the secondary is the reconstruction. So it shouldn't interfere with it.
Right.
So, all saying that, I mean, a mastectomy will take away around about 92% of the breast. Everybody would have about 8% left. But it's very superficial. Whatever it is going to be above a reconstruction. So it could be palpable, could be felt by the patient. And it's also available for treatment. So if the patient does need radiation afterwards, it is available to the radiation. But would never reconstruct, knowing that it could ever interfere with monitoring. So if a lady does get a reconstruction on one side, it doesn't mean they need any investigations. It doesn't need a mammogram on that side anymore. But on the contralateral side, the normal breast would still undergo the normal surveillance, either mammogram or MRI.
Right. Okay. And Does it have any risk, though, of causing relapse again in breast cancer patients, do you think?
There isn't anything that we would put in to increase that risk.
Right.
The implants, the silicone implants, are totally inert. They don't have any risk in themselves. The free tissue is autologous, their own tissue, would not have any increased risk. And if they're trying to think that there is something hidden behind an implant or in reconstruction, that is not possible without being under surveillance.
I see. Dr. Abil, what was your experience like with chemotherapy, or with the whole treatment? What was your experience?
I've been through most of the modalities of treatment that your guests have been talking about. So hopefully I can help your viewers understand what it is like. So yeah, I've been through chemotherapy and hair loss, but all came back luckily, So it was quite tough, of course, going through the period of chemotherapy, and it makes you quite tired, and but you kind of get used to it, and you carry on being a mom and a wife and everything, and just doing your usual job. And it takes a while to recover from the effects of chemotherapy, but then you recover almost back to normal self. Other treatments I had, which was mentioned briefly, is these targeted therapies. So I'm currently on some treatment which is called BARB inhibitors. These are very nice invention that I'm happy with.
So it's a new trial drug?
New trial
medication,
which is specifically targets the BRCA mutation, the cells that cancer cells with the BRCA mutation. So it's very, very useful in patients with similar to my case who have a family history of breast cancer and having the BRCA mutation. Because as mentioned before by Dr. Payne, that the BRCA gene is very important in the cell to control the behavior of the cell. In basically in everyday life, there will be DNA damage in each cell, and the BRCA gene controls the cell by fixing this DNA damage.
I see.
So how the BARB inhibitor works, which I'm taking olaparib, for example, is that it inhibits the BARB enzyme. Yeah. The BARB enzyme is basically, so it will block the cancer cells from fixing the DNA damage in the cell. Yes. By doing that, the cancer cell will die because DNA damage is incompatible with the life of the cell. So that's how it works, which is very effective compared to chemotherapy, is that it only targets the cancer cells, so I don't have to lose my hair. I don't have to have all the other side effects of other, all the other side effects of chemotherapy that, most patients suffer from. So it's quite useful to have that invention.
Yes, that's excellent.
Yeah.
And it's actually trying to put yourself also at risk in a way, isn't it? By trying out something that hasn't been sort of medically tested before?
I was lucky to be actually, I mean, the trials of the olaparib are almost getting to an end now.
I see. Right,
so
good.
it's been tested for, I think, almost 15 years.
Oh, right.
That's apparently, I didn't know that, although being a doctor, but I didn't know that it takes about 15 years for the drug to be on the market.
Yes,
but still, I think there's still some sort of trials at the moment still going on.
I'm glad to hear that.
So, but it's been really good, and lots of other BARB inhibitors are still trials going on, which is going to be even more targeted, and lots of things going on at the moment, which is really good.
I'm glad to hear that.
And knowing all the advances in genetics and the whole genome sequence that everybody's talking about, and that we'll know more and more of how we can target these cancers, hopefully.
Well, stay with us, because after the break we will actually come back and speak to some more experts about the issue of breast cancer. Okay, stay with us. Welcome back to the show. Ms. Payne, how do patients overcome the psychological trauma of having their breasts removed, should they have to do that?
It's something that is a huge part of their overall journey is to for us to actually be able to help them, to be able to offer something. So they may lose something, but to gain. And I think that is very important, is to have the whole team. And our team is the clinical psychologist, the breast care nurses, which are essential, and to be able to give them all the information they need for that journey. And I think that, as we have mentioned before about the internet, how much information there is, coming back, talking about it, having a long consultation about what we can offer to help them through this. And working as the patient, as the lady, as an individual, and tailoring it to them.
Yes.
And I think breast reconstruction has a very big influence on that as well, to be able to offer something that gives them something back as well. Yeah.
Abir, in your experience, how important is it to have the support of family and friends while you're going through the journey of dealing with cancer?
Of course, it's very, very important, to have, someone around you that can understand. I was very lucky to have my husband and my kids, very understanding of my situation. To also have family members here with me in the UK too, also, who had, one of them had had already been through the same process, unfortunately. So it's really important to give you all the emotional support you need, and also having. It's very strange that having already had other family members have had this problem before, having had breast cancer, and unfortunately one of them died from breast cancer. That you kind of, it's not like get used to it, but you kind of know or expect what you are going through. And although every one of us had different type of cancer or different type of treatment, but it has helped a bit that you kind of knew a bit about what to expect, and but still you still need a lot of support and from, of course, your doctors and everybody around you, which is very, very good.
How effective do you think that cancer charities are in spreading cancer awareness amongst women?
I think they are doing a really great job. In either just as an awareness, increasing the awareness of breast cancer, and fundraising, also in to support research, which I'm being benefiting from, and also in helping patients while they actually having the treatment. They have been really doing amazing, job in this matter here in the UK. So I've been lucky enough to have even one session of look good, feel better, which when I have been, I lost all my hair, and somebody came from all the nice department stores with a big goodie bag, lots of makeup, and how to make you look nice, and which was so that's all supported by the charities, which is even these small things can make a lot of difference to the how the patients feel about their illness and how they feel about themselves, which is very good.
Excellent. A reduction in mortality from breast cancer requires that all professional groups involved perform to the highest standards. Therefore, the quality of pathological services is of the utmost importance. Pathologists almost invariably make the definitive diagnosis of breast cancer and additional features of in situ and invasive carcinomas that have prognostic significance are also required to determine the most appropriate management for individual patients. With me on the phone is Dr. Dia Kamal, a consultant and head of Department of Cellular Pathology at Mid-Essex Hospital NHS Trust. Welcome to the show, Dr. Kamal. I'm sorry to have kept you. Dr. Kamal, what is your role as a pathologist in diagnosing breast cancer?
Yes, pathology is important in diagnosing breast cancer because it's a gold standard way of diagnosis. The diagnostic process would involve colleagues like clinician surgeons who examine the patient clinically. Then it would involve radiologists who would do mammography or ultrasonography for the breast lesion. And then it will be confirmed through histopathology or pathology diagnosis. We look at cells under microscope, and we examine two types of specimen, either cytology or tissue biopsy. And both are important in confirming and determining the breast cancer and what type of tumor. These specimens come to us through either a patient who found a lump in her breast or a lesion. She will seek medical attention, and this will be taken as a biopsy or SNA coming to us. The second sort of specimen is coming through breast screening, where there is a lesion in an abnormality detected by mammography, and the diagnosis will be confirmed by pathology.
I see. Well, can you actually elaborate on the pathology report, please? What's it like?
Pathology report is very important, not only in diagnosis. So we give a diagnosis, we tell what type of tumor, but then we will recommend the management for the surgeon and clinicians, oncologists. The report usually encompasses like diagnosis, tumor type, differentiation status, which is a prognostic significance. In addition, it will tell about vascular invasion if the tumor invades the blood vessels. And most importantly, in view of the management, we tell about positive hormone receptors. And by a simple test with immunohistochemistry, we can determine this patient to be taken with, in addition to surgery or chemotherapy, hormone anti-estrogen treatment, for example, tamoxifen, or more importantly, we do HER2, which is an oncogene, a gene detected in breast cancer. And if it is HER2 positive, patient will take Herceptin, which is a sort of targeted therapy. So these are all items included in the initial biopsy report. Then the clinician will get this report and we plan his management. The surgeon might excise the tumor. Most of the cases, they will excise surgically the tumor. Again, they will send this tumor to the pathology lab, in which we actually assess and monitor his therapy. Assess and monitor response of tumor to chemotherapy, if she has taken, for example, chemotherapy prior to surgery. We can also detect if the tumor involving lymph nodes, which is very important in prognosis, and we can detect if the tumor is completely excised and the patient will be disease-free survival for a long time. So, in fact, we are, in the report, we're giving diagnosis, plan for the management, follow-up, monitor the therapy, and prognostic significance to this tumor for the surgeon and the patients.
I see. Dr. Kamal, how do you compare the process of diagnosing breast cancer between here and the Middle East?
It's a bit of a difficult question to me because I haven't worked in the Middle East, but as I can assume a few things. First, we have actually here in UK we have a screening program, which the screen ladies from age 50 to age 70. I assume it's not available in the ladies in the Middle East. We also have sophisticated techniques detecting proteins. We call it immunohistochemistry. This is present in the Middle East, but maybe limited more than here. Also, recently we do genetic testing, like molecular pathology. We detect certain genes by doing oncotype DX, for example, extracting the DNA from the tissue, and we do the oncotype DX. And accordingly, this test is very extensive, looking at all the genes of this tumor and determine what sort of treatment and therapy which can be targeted against the cancer cells only. These sophisticated techniques are very expensive and they are very elaborate. I assume the Middle East is slightly behind these techniques, although actually now we have the internet resources and this can spread everywhere, but I assume it's still slightly behind. The second issue here, which I should elaborate, is the awareness of ladies in Europe and maybe in the West. I think they are more aware, they can examine themselves. I'm sure this depends on the socioeconomic status. You have many ladies in the Middle East who can examine themselves and detect if there is any abnormality. But I think the awareness may be a factor, unfortunate factor, which the ladies in the Middle East are maybe slightly not fully comprehended by the how to examine themselves and how to detect early breast cancer, in addition to screening program, as I mentioned before.
I see. Well, Dr. Dia Kamel, Consultant and Head of Department of Cellular Pathology at Mid-Essex Hospital, NHS Trust, thank you very much for joining us, and sorry to have kept you.
Thank you very much.
Thank you. Bye-bye. Ms. Payne, what do you think of breast implants, and does it carry any risk of breast cancer, generally speaking?
Generally, yes. I suppose a lot of patients come into my clinic with this knowledge that in the early 90s there was a problem with breast implants, which was a moratorium by the FDA from the States, who then blanketly banned silicone implants until more research was done. In the UK, we never banned the implants. There was no evidence to show that it was causing any problems. And it wasn't to do with breast cancer, it was to do with some of the arthritic conditions. So we have always advocated that silicone implants have been safe in every aspect. I know that there's been a lot of talk with the PIPs, and the fact is the manufacture of them was the problem rather than what it was causing, so they were rupturing. So in my mind, an implant has given a lot of people a reconstruction that is suitable for them. It's not suitable if you're having radiation because it grips the implant and it distorts the breast. But the actual implant itself is completely inert silicone made of cohesive silicone in the middle. So if you cut it, I say to my patients, these are jelly tots. In other words, you cut it, the middle doesn't run. And the fact that it is then underneath a muscle or the chest muscle or underneath the breast tissue, the envelope that did have the breast tissue, so it's easy to surveillance. But the main thing that I think is quite interesting is there's obviously a lot of people who have breast augmentation, that obviously just for enhancing the breast. And it has been shown that this decreases breast cancer, not the risk of it, but these patients are so breast aware that they do self-examination, so they find it earlier. So in fact, if you have the breast augmentation, you find that these ladies are actually finding their cancers early.
I see.
So it decreases your risk.
Right.
So,
and I mean, speaking of obviously being aware of breast cancer, in your condition, how did you actually become aware of a tumor?
Well, that's an interesting
beginning.
story, but it's not the normal. But
Yes.
Because of the family history, I was already on the screening program, which at the time, that back in 2005, I had only mammogram.
Yes.
Which now they do mammogram and also breast MRIs for screening, as far as I'm aware. But at the time, I had mammogram, but unfortunately, 2 weeks later, I felt the lump myself. So because I had at the time the breast tissue was dense and it was difficult to detect the tumor. So I felt it myself. I was aware, of self-examination, of course, and so yeah, I would advise all women to have self-examination, especially if they have a family history of breast cancer. Of course, they should, if they have a family history of breast cancer, especially at a young age, which is like similar to my case, they should go and speak to their doctors and and tell them this, so that then they can give them advice and counseling, maybe with one of the geneticists, about the risk of possibly having a familial type of breast cancer and maybe doing the BRCA gene mutation, and then they can have an informed decision on what they want to do, whether they can do prophylactic mastectomy to remove both breasts and also the ovaries, which will reduce the risk of developing breast cancer. So yeah, that's my advice to them. And of course, just to always be aware and vigilant about examining your breast, and any lump, to just seek medical advice.
That's very important.
Very quickly. Yeah.
Following on from the pathology report, what kind of treatments are available for cancer patients? With me on the phone is Dr. Hafiz Al-Ghurabi, Consultant Clinical Oncologist at Southend University Hospital. Welcome to the show, Dr. Al-Ghurabi.
Thank you for inviting me.
Thank you. Can you tell us about the ways breast cancer patients undergo treatment, please?
So, breast cancer treatment has actually changed a lot over the years. Decades ago, women would have been confined to having mastectomy and maybe some radiotherapy in a more archaic way, but things have moved on dramatically during this time, and now women's treatment is more individualized. And so we rely a lot on biopsies, in other words, specimens of tissue taken from the cancer to guide us as to how best to manage patients. And we do that within a context of what's called a multidisciplinary meeting with all the relevant specialities involved so that patients get an agreed, a uniform opinion. And so we use the details from the biopsy and the details from the surgery that has been undergone in many cases to guide us as to how best to tailor treatment a little bit better for that individual patient. So many patients have, or viewers I should say, are fully aware of the fact that cancer is not just one disease and that you need different types of treatments. So for the mainstay of most cancer patients, though not all by any means, of course, many patients would have had what's called a wide local excision or a lumpectomy, where the lump is removed. And then from that lumpectomy, or from the biopsy in some cases, we use the details of the pathology, in other words, the size of the tumor, the grade of it, in other words, what it looks like under a microscope. Does it divide slowly? Does it divide a lot? We use the number of nodes, if any, that are involved, and that's usually been done in a procedure called a sentinel lymph node biopsy. And we use other factors as well to try and determine whether someone, after a lumpectomy or just the surgery, will need what we call adjuvant therapies, in other words, treatments after surgery. And that could be, in many cases, for many women, just radiotherapy only. And in some cases, if they have receptors or attachments on the surface of the breast cells, some hormonal therapy.
So what is the difference? What is the difference, Dr. Al-Gharafi, between chemotherapy, radio, and hormonal therapy? What's the difference?
So what we know is additively, these therapies all go about in terms of to increase the patient's survival, reduce the risk of it coming back, and they are different. So chemotherapy, many people will see it as they associate it with hair loss and going into hospital for chemo injections, and that's essentially what it is. It's essentially drug therapy delivered to try and limit or stop cancerous cells dividing, and it's been given through a vein in many instances, and other times it's given as tablets. And essentially, as I said, it's trying to stop those cells dividing. Unfortunately, it also affects normal cells as well, and that's why patients get the side effects of therapy, like the hair loss and the nausea, etc. Radiotherapy is... Sorry, before I go on to the radiotherapy, and there's also, of course, other forms of what some people regard as chemo, though it's not really, some form of targeted therapy. And that is given not perhaps in the setting after surgery alone, but in individuals where the cancer has unfortunately spread to other parts of the body. And I can talk about that later if you wish. In terms of radiotherapy, all radiotherapy is essentially X-ray therapy, X-rays. And it's delivered to cover the whole breast, just to try and prevent any cells that may have seeped at the time of surgery from dividing early on or hibernating and later causing trouble. And what we know from radiotherapy treatment is that it can reduce the risk of a cancer coming back by at least 50%. So it's very effective treatment with side effects that are quite manageable on the whole. And it's essentially X-rays delivered via a machine called a linear accelerator. And it is essentially just trying to get rid of as many of those cells that may be lingering behind as possible. Some people are looking at doing that kind of radiotherapy at the time of surgery, and that's still an ongoing question. And whilst radiotherapy has changed a lot over the last few years, it's essentially still remains a key component of our treatment pathway anyway. And most patients who've had a lumpectomy will need it. And even some women who've had a mastectomy where they've removed the whole of the breast tissue may also need it in certain circumstances also. This is different, of course, from hormone therapy, where if women have an attachment on the surface of a blood cell, of a breast cell, either an estrogen receptor or a progestogen receptor or a Herceptin receptor, we can try and stop estrogen or progestogen binding to that receptor and causing that cell to divide by using various drugs, some of which have been around since the late 60s, like tamoxifen, and some of which have been around for a few years and which are extremely effective. So drugs like Herceptin, which has kind of revolutionized therapy for a group of women who have this Herceptin receptor. So the therapies are very different. You know, we've talked briefly about surgery and mastectomy, radiotherapy, chemotherapy, and hormone therapy, and all these together complement each other in terms of trying to reduce the cancer coming back, trying to increase one's survival. And the future will be very, very exciting as well, because although we may still end up using some of these modalities, I think they will change, because we are moving from an era of just giving patients standard therapy, and we've given it as a one-size-fits-all, but with advances in molecular profiling and better understanding of the genes and the Cancer Genome Atlas, trying to identify all the different mutations involved in breast cancer, our therapies will become much more geared to a particular patient. In other words, instead of giving wholesale chemo to everybody, or wholesale radiotherapy, or hormones, we'll be able to better identify what a particular patient, what a particular lady may need for her breast cancer, and individualize and tailor that therapy for her much, much more better for the future.
I see. Are female patients normally well informed of all the different therapies, obviously, and obviously all the consequences of having therapy?
Yes, obviously with the explosion of the internet, most women are very, very much aware, and if they're not, then their relatives who come with them will be.
Right.
And so usually by the time they've come to see an oncologist, they've been told they may need this, they may need that, and a lot of them will have done a lot of Googling and will have done a lot of searching, and are aware of what to expect, and even aware of what new therapies may be coming in the future, and whether they could avail of those as well.
Yes, that's true. Because, I mean, because of Google and the internet and the website, you'll find that even sometimes patients are actually better informed than the actual doctor, which is quite funny, actually, I'll find sometimes. But I guess, that's what Google and the internet is all about. So you've got a whole wild world of medicine open to it.
And that's good for women, because it's nice to have a woman who's come empowered with knowledge.
Yes.
And comes to your clinic and it knows what to expect, and asks all the relevant questions, so that when side effects do occur, for example, they know what to expect. So that's always empowering, yes.
Yes, exactly. We like women power.
Yes.
Dr. Al-Ghurabi, thank you so much for joining us. It's a real pleasure having you. Thank you.
Pleasure. Thank you.
Thank you.
Bye-bye.
Bye-bye. Ms. Payne, dealing with female patients that suffer from breast cancer and having a big role in enhancing the appearance of these women to help them lead a normal life, how important is this to you?
Very. It's my job. I have to say that is the primary aim, is that if I have a patient that I've seen all the way through and I see them right at the end, and that can be sometimes about 18 months to 2 years down the line, even from a primary mastectomy and reconstruction, by the time that I do a nipple reconstruction, you do the tattoo, you tinker a little bit just to make everything even, or you need to do something on the other breast to lift or to reduce it, then they come to my clinic and they are happy and I discharge them.
Excellent.
That is
That's a satisfaction.
That is total, yes.
Glad to hear that.
Yeah.
And finally, Dr. Abir, what message would you send to women suffering from breast cancer?
Well, I say be strong, and there is always hope at the end of the tunnel, never lose hope, and just what I've always did, and you can see I'm just smiling still after all I've been through.
I love your smile.
It's just, I never look back. I just keep looking forward and always have hope in God, and I trust, my doctors, and I hope that with all the
I think that's a
cancer,
very important part, is
yeah,
trust, building that trust.
yeah,
with it.
and be as mentioned by your speakers as well, that always be aware and Google things and read more about it. I actually, my doctors, I was lucky that I tell them that that what about this, and they were
Being
quite
doctor
happy.
yourself as well.
Yeah,
Yes.
I mean, but even not that, just as a patient, you have to be more aware of what's going on and ask. Don't worry about asking, and just I think there are lots of hope in the future, which is keeping me going, I hope.
I'm glad to see
So,
that, and I can see that in your smile,
Thank
your
you.
flashing smile is so
Thank you.
beautiful.
Thank you.
Dr. Abir, we do wish you all the very best
Thank
in the future.
Thank you.
And may you continue living a happy and healthy life.
Thank you.
Unfortunately, we have come to the end of the show. I would like to thank Miss Caroline Payne, consultant plastic, reconstructive and cosmetic surgeon, for joining us today, and Dr. Abir Khalifa, pediatrician and BRCA1 carrier, for taking part in the show and raising awareness amongst women suffering from breast cancer and BRCA1 carriers. While we have discovered new ways to treat breast cancer, we have not had a great effect on the important outcomes, which is preventing breast cancer and making certain no one dies of it. Over the past decades, government, private and charitable sectors have invested billions of dollars towards breast cancer, from which we have developed new tools and technologies and a new understanding of basic biological processes and risk factors important in breast cancer. But despite these investments and discoveries, very little has changed in terms of breast cancer incidence, morbidity and mortality rates over the past 40 years. An inspirational quote that really captivated me is, "You never know how strong you are until being strong is the only choice you have." Goodbye.